let's talk about trabeculectomy consent. And this is aimed for our patients, and hopefully they'll be able to watch this video and just get a bit more detail or recap some of the information we tell all our patients before trabeculectomy. And I thought we'd just chat through it, Peter. I'll present the slide and you can make comments along the way.
Sounds good to me.
So with trabeculectomy, and this is a patient, so we've decided that they need trabeculectomy surgery or glaucoma drainage surgery, and the whole aim of the surgery is to control the intraocular pressure. These are often patients who've tried all the medical therapies and they're on what we call maximally tolerated medical therapy. They may have even had laser procedure, but these procedures and medications just aren't getting the intraocular pressure to where we want it, to a point where we can keep their glaucoma vision loss to a minimum. So trabeculectomy itself is a drainage procedure, and it allows the fluid to get out of the eye. And the thing with that is you can't just make a hole in the eye, because the eye will go too soft, and that in itself is very damaging. So it needs to be a controlled release. So we fashion a small trap door or flap valve, and it allows just controlled fluid, or what we call the aqueous, to come out of the eye. And this allows the pressure to be lowered and also keep the pressure more even. So Peter, what do you tell patients about the trabeculectomy and why it's being done?
Well, I'd agree with what you've said there, Graham, that really the first thing I would emphasize is that they are often at the point where medical therapy and or laser therapy has ceased to be a useful further option. And so it is major surgery for the eye. And so I do emphasize that this next step is a big step. This is major surgery. However, it is an operation that has been around since 1967, and it's been progressively improved since 1967, such as that it's a very sophisticated operation now. It's our gold standard glaucoma filtration surgery, and in the hands of a good surgeon, you can be looking at anywhere between 90 to 95% plus success rate. So although it's going to involve a bit of work between the surgeon and patient, and although it's major surgery, this is an option that really can help to stop people going blind from glaucoma.
Okay, so if we look at the procedure itself, I do it as a day surgery, and this has changed. I remember when I was training 20 years ago, it was more of an ordeal. You'd have to be admitted the day before. You'd be in surgery on the day, and then you may spend 3 days or even a week in hospital as an inpatient. So we've come a long way since then. I do it as a day surgery. The anaesthetic can be local or a general anaesthetic, and this very much depends on the patient and the surgeon. I must admit I do most of my patients under local anaesthetic with sedation. So they are awake during the surgery, but my anaesthetist is very good. That they can infuse sedation and make the patient as sleepy as necessary, just to keep them comfortable. And with the local anaesthetic, they're very good with putting the anaesthetic in and giving the best operating condition possible, keeping the patient comfortable, pain-free, and also for the surgeon so that the eye isn't moving. They have to be able to lie flat and still for the duration of the surgery, and again the duration does depend on the complexity of the case. So most times it's in about 40 to 60 minutes where we can do the surgery. And I like to put a bit of tape around the head, and it sounds a bit strange to some people that we have to tape their head to the bed, but it's quite gentle, the tape, and it just allows the patient to just keep their head still, and it also helps with the surgery too. There's a bit of counter traction for when the surgeon is actually operating. So what do you do during the procedure along these lines, Pete?
Yeah, very, very similar, Graham. A lot of our patients travel from quite long distances at one end of the spectrum, or maybe they live alone or only I, um, or they're very elderly. So we may keep them in for one night sometimes, you know. I use a mixture of local and general anaesthetic, and certainly in the younger cases, I always use general anaesthesia. I think it gives you a few advantages in the younger cases, but I think local anaesthesia with sedation is absolutely fine. And the key here is that whatever method of anaesthesia you use, what you're really looking for is a very experienced surgeon and a very experienced anaesthetist who have worked together for years. And that's what gives you the best cocktail and the optimum conditions, as you say. And I agree with you fully that if someone is having local anesthesia, they lie flat, their head and neck are rested in a very soft headrest, which is very comfortable. They have a pillow underneath their knees, which takes all the weight off their back. They have warm blankets around them so that they don't get cold in theatre. Theatres can be quite cool places sometimes. And patients find it very reassuring, as you say, to have a little bit of tape around their head. And all that really does is it keeps them in that comfortable position with their neck comfortable, and it actually helps the patient to keep still so they don't have to worry about moving their head.
Mm. I think this is also an area we need to look at our patients very, very carefully, and you get so caught up just looking at their eye that you don't notice that they've got back problems or hip problems, or they may have other medical problems like respiratory problems where they can't lie flat. And yeah, if we can assess all this in the clinic beforehand and discuss it with the patient, it means that when we actually get to theatre on the day, that we're prepared to position the patient so that they're comfortable, and just make sure that they can lie flat and still for the duration of surgery. Otherwise, it can be quite a challenge if they can't.
Well, I think you're right, Graham, and I think that preoperative assessment is critical, and I'll sometimes spend several consultations actually preparing someone for all the various issues depending on the degree of complexity. So, for example, there may be personal issues like patients may be claustrophobic and they just cannot stand enclosed spaces or have their face covered. They may have had previous bad experiences when they've had MRI scans or things like that. And it's very important to detect that. I never operate on patients who've got an active cough or an active infection. Let's say if the patient's got a nastily infected leg ulcer, well, you need to get these things better, get the leg ulcer better or get the cough better before you operate. And I know we're going to move on to other things like drugs that thin the blood, but all these kind of issues have to be decided beforehand. And then there are other quite important conditions like Parkinson's disease, where the patient may have a very bad tremor and you may need to get the timing of their medication just right for surgery. Restless leg syndrome can be very important because the patients move a lot when their legs twitch. So what we encourage is that patients really talk to us and tell us about any worries they have or any conditions they think that are relevant. And sometimes we have what's called a trolley trial, where we'll actually lie someone flat for half an hour in the clinic, just like in theatre, with a pillow under their head and a pillow under their knees. We might cover their face with a thin drape so that it mimics surgery, and patients can actually find out whether they can tolerate it or not.
Mm. Yeah, no, a lot of good points, because patients think it's just about their eye, but it's their totality that all needs to come together to get the eye surgery just right.
Absolutely.
So for the surgery itself, it's a matter of forming a drainage from the eye. And whenever you make incisions in the eye, the body always wants to try to heal it back over. And this is one of those few operations that we do that we actually don't want the drainage to actually heal over, because that would mean that we can't control the pressure and the trabeculectomy won't be successful. And we're actually battling against the healing factors of the body when we do trabeculectomy. So one of the things we apply is a substance called mitomycin C, and it's actually what we call anti-fibrotic. So it actually prevents the scar tissue just in that particular spot, and you have to be very careful with your application. You just want it just where that trapdoor is, and it allows the trapdoor to remain draining for long-term success. There are other substances that other surgeons may use, but I think the mitomycin C, particularly over the years, has been the most successful, at least in my hands. And then after the surgery, an iPad and a shield is applied.
I think those are the general principles, and I think the use of mitomycin C with trabeculectomy is now the gold standard. And it's very important indeed that your surgery is performed by someone who's actually done an accredited fellowship and trained in using these techniques, because as you say, these are fantastic drugs, but they do need to be used very carefully and very precisely. With all things going well, it's a fantastic operation that works very well.
Over time, that there'll be other types of drainage surgeries that are developed. But trabeculectomy, as you said, since 67, and it's had quite a few developments since then to make it more efficacious and to make it as safe as possible. But it really is the mainstay of glaucoma drainage surgery. Certainly there's tube surgery, and we can talk about that in another lecture.
Yeah, no, I think you're right, Graham. I mean, sometimes it can be very difficult for a patient because they are exposed to all these different options. There's various lasers like selective laser trabeculoplasty, there's trabeculectomy, there's trabeculectomy with mitomycin C, there's tube drainage surgery, as you say, and then there's a whole range of things called MIGS surgery, microinvasive glaucoma surgery. And again, the key here is to be working with your surgeon. Your surgeon will have looked after you for a while, and they will help working with you to select the best procedure for you. And so sometimes you'll read things in the newspapers or magazines that sound like some bright new idea, but it may not be appropriate for your type of glaucoma. And if you look at just the sheer range of things that can cause glaucoma, you could easily find 300 different things that could cause glaucoma. Everything from genetic forms through to trauma, inflammation, even tumours, all kinds of things can cause glaucoma. And so your surgeon will know your case and be able to select the best operation for you.
Yes, certainly in these days of the internet and common press, things you see on television, the public is inundated with information, and it's very hard to actually process all of the information. And yes, as you say, that your surgeon is the best one to discuss all those different options.